Start, ma'am.
Hello guys, welcome back. So today we are going to deal with the second part of orthopedics. So yesterday 2 hours we have done some important questions, we have done some important bits, and today we are going to understand few more important questions, few more important topics which might come in your exam. Right? So let's get started with the questions again. So this is the continuation of the questions. This is the first question coming up. A 17-year-old girl had a thigh swelling which had a discharging sinus from which a bony fragment came out. The parents were concerned. What was it? So this was the question which was asked in the previous exams. So what was it? So I know you all already know what is it. So let me just make clear for few people who want to understand more. It's fine. So this is a question. It shows that a 17-year-old a discharging sinus, right? So here there is a sinus. So whenever there is a word sinus, it means it is related to your chronic osteomyelitis. So in case of chronic osteomyelitis, there is an infection with the bacteria, and now the bone and the marrow has been infected, right? So that is the term osteomyelitis is dedicated to. Osteo is bone, myelus is marrow, itis is inflammation, and this inflammation is because of the infection. Fine, and this has been since many months, or so hence it is called as chronic osteomyelitis. And here, what is the pathology? So the pathology in chronic osteomyelitis is that the bone gets infected and there is a formation of the dead bone. So there is a formation of the dead bone, that is your sequestrum. So what is the definition of sequestrum? Yesterday we have already learned what is definition of sequestrum. So it is a dead, devitalized bone. Right, so there is a dead bone because of loss of blood supply to it, it becomes dead. And on the x-ray, how is it seen? On the x-ray, it is seen as a dense sclerotic bone, right? It is seen as a dense sclerotic bone which is surrounded by a lucency, halo of lucency. So that is the definition of your sequestrum. And what is involucrum? Involucrum is newly formed bone. Involucrum is a newly formed bone. Involucrum is a newly formed bone. This is because of the reaction. There is a new bone formation which is called as involucrum. And if you all know what is cloaca, can someone answer for me what is cloaca? Yes, most of you have answered it right. The answer is Khan. Vikas has answered it B. So Vikas, what is cloaca? Cloaca is the openings which you see on the bone through which the sequestrum comes out, right? So here the answer is what has come out, right? The sequestrum is the answer here. So if you see, we have understood what is involucrum, what is cloacae, and then what is sequestrum, and then loose body. Loose body is just an osteophyte which has been detached from the parent bone, and it is usually seen in the joints, right? In the knee joints or any usually we see it in the knee joint because that is the large joint, and you will see the formation of osteophytes in case of osteoarthritis, and these loose osteophytes will get detached from the parent bone and will present as a loose body. So the answer, which has come out, right? What was come out? That is the sequestrum. So the answer is C. Cloaca are just the openings on the bone through which it allows the sequestrum to come out. Involucrum we have already dealt yesterday also, today also, that is the new bone which is formed is the involucrum. And here what you have to remember is on the x-ray you will see that the dense sclerotic bone, that is the sequestrum, which is surrounded by halo, and the involucrum is the new bone formation, right? Involucrum is the new bone which is formed along the older bone, that is the involucrum. Right? So these are the terminologies which you have to remember for chronic osteomyelitis, and this is also very important topic for the exam. Right? So that is the answer for it. Now let's move on to the next question. So this is regarding the what is the most common site, most common affected in TB hip. So here they are asking about the TB hip. right? So tuberculosis is one more important topic which you have to understand, right? And remember for answering this question. So coming to the tuberculosis, let us understand few important things from tuberculosis, and then we'll go back to the answer. So coming to the tuberculosis, as you all know, it is so Harsh and Avilo Medicine has answered it one. Okay, let's see whether it is right or wrong, right? So the first, starting with tuberculosis, it is by the bacteria that is the most famous bacteria. It is Mycobacterium tuberculosis, right? Yes, many of you have answered it correct. Harsh, Avilo Medicine, Harsh, Vikas D and Med Psycho. So the answer is acetabulum, as they have mentioned, but let us understand a bit of TB hip and then go back to the question, right? So first, tuberculosis, this is caused by the organism that is Mycobacterium tuberculosis, right? And why this is so special? Because the presence of the various, so this TB, it has been a very dreadful disease in the past because there were no medications which were acting against it, and you can't culture this TB, right? And you take a longer time to culture this TB, and the genetic mutations occur in this are really fast. So we have a set of drugs now available, and now this disease is curable, but still India is suffering with tuberculosis. And usually this TB is a different type of set of disease. It is a delayed hypersensitivity which affects the T cells, and your immune system is compromised, right? So what is that? Various things which you have to remember is you can get this question as an integrated question. So let us learn little detail about every aspect of it, so that even if it is integrated with the other subject, you can answer it easily, right? So first, I am teaching according to microbiology, that is the mycobacterium is having what okay, Avilo Medicine, I will answer your question later. So first, let us discuss that mycobacterium is the bacteria, and because of the presence of this mycolic acid, the stain which is used in tuberculosis is Zn staining. So it is used the Zn staining, that is the Ziehl-Neelsen staining. Very good. And next, what you see on this. So on the biopsy, you stain it and you see what are called this tuberculous bacilli, which are present in groups, right? And then you take the biopsy, and biopsy, what you see? Again, you see granulomas. This is what you have to remember. This granuloma is very specific for TB because it contains the caseous necrosis in the center, which is surrounded by the lymphocytes, right? And then you have your epithelioid cells. What are these epithelioid cells? Which are nothing but the epithelial like cells. So it is epithelioid cells, and you will find n numerous number of lymphocytes, and the most important one is central caseous necrosis, right? So that is the granuloma which you see in TB. That is the biopsy description, right? Now coming to your skeletal tuberculosis, let us see a bit of skeletal tuberculosis. So in skeletal tuberculosis, so this is always secondary. That means the primary is present somewhere else and it travels through the blood. That is the hematogenous spread. There will be a hematogenous spread to the skeletal system. So the most common skeletal involvement is, so can somebody answer this? The most common skeletal involvement is seen in which part of the bone? It is seen in the spine. This is what you have to remember. So that is the spine which is the most commonly involved, right? In the spine, the dorso-lumbar region again is the most commonly involved, right? And then comes your dorsal vertebrae. So the dorso-lumbar vertebrae, and then your thoracic or vertebrae, then your lumbar. Yes, spine is very correct, Khan. So that is the involvement. And after spine, what is the most important region? So after spine, it is the hip. So it is the hip which is most common after the spine. So if you want to talk about the most common larger joint, it is the hip. And after hip, it is the knee joint. So this is how you have to remember. If somebody asks what is the most common skeletal involvement area, that is the spine, and then comes the hip, and then comes the knee, right? And in the hip joint, here the pathology always starts mainly from the acetabulum. So this is the most common area. And then you have your Babcock's triangle. This also you have to remember, the Babcock's triangle. And then you have your femur head and then the trochanter region. So these are the various areas where the TB can occur. So Babcock's triangle is that area. If you say this as head, so the small area, subcapital area, anterior posterior subcapital area, you will find the smallest area where the tuberculosis can occur, because of the reason mainly because of decreased macrophages, where the immunodeficient area. So that is the Babcock's triangle in the femur head. Right, so that is the part where it is frequently involved. And now let us see little bit of TB hip and its stages. A quick revision of TB hip. So TB hip has 4 stages, as you all know, and there are 4 first stages: the stage of synovitis, and then there is a stage of early arthritis, and stage of late arthritis, and advanced arthritis, right? So these are what you have to remember regarding the TB hip. And in this 4 stages, what you have to remember is the first is synovitis. So whenever there is a word synovitis, that is the inflammation of the synovium joint. So whenever there is an inflammation of the synovium joint, that is the synovium gets inflamed and there will be filling of that synovial fluid. So this inflammation, and you need space to accommodate the synovial fluid, right? So this space is given by this position called Faber, that is flexion, abduction and external rotation, is where you see the attitude of this limb in case of stage of synovitis. And this is also called a stage of lengthening, and this lengthening is apparent lengthening. So this is the apparent lengthening which you see here, right? And then you see a stage of early arthritis. Stage of early arthritis is, again, there is attitude change, that it becomes farther. Now there is some amount of apparent shortening, you see, because there is the involvement of the bone. So there is the involvement of the bone. So there is early arthritis, and then late arthritis, again it is farther, but here you see what is called as a true shortening. You see what is called as true shortening. Yes, early arthritis is farther. Yes, Khan, it is right. And then there is an advanced arthritis, where in case of, if you remember, TB hip mainly affects the bone, right? So here there will be involvement of bone, so there will be subluxations and dislocations, right? So involvement of the cartilage is late in case of tuberculosis, because this TB doesn't produce any enzyme such as which degrades this cartilage, right? So it starts from the periphery and then enters into the central part of the bone. That means the joint. So it starts from the periphery of the joint and then it enters the center of the joint. So when it enters the center of the joint, already there will be this erosions of the bone, and there will be a subchondral bone which is eaten up, and then these joints become very loose. So this is called subluxation and dislocation stage. So that is the advanced arthritis, where you see subluxation and dislocations of the hip. So here you have to remember 2 important things. So one is your wandering acetabulum, and the second one is the motor and the pessile appearance of TB. So these 2 are seen on the X-ray, and according to the classification which was given by the Indian orthopedicians, that is Shanmugasundaram classification. So according to the Shanmugasundaram classification, you will see these 2 important points. So one is wandering acetabulum and one is motor and pessile appearance. So what is this motor and pessile? If you see in the kitchen, you have something called as this for preparing your spices. So there is something like which is like bowl, and then you have something like a stick, and you do pounding of those ingredients which are put inside it, right? So this is motor and pessile. And similarly, wandering acetabulum. So if you think this is the acetabulum, this is the femur head. And now what will happen, because of this bony because of the tuberculosis, the acetabulum become wider and the femoral head will become smaller. So this will become like a motor and the pessile appearance, or the femoral head will come down where the space is empty here, or it might proximally migrate where the space is empty down. So because of these positions, so up and down, you will see that acetabulum as wandering acetabulum. right? So these two are important things which they might ask in your exam. So these two are seen mostly in TB hip, right? So these are the 4 stages of the TB hip, and yesterday we have discussed a little bit of TB spine. And coming to the TB knee, I'll just add one word about TB knee that will complete your whole chapter of TB, right? So in TB knee, you will have what is the most important thing which you have to remember is your triple deformity. So there is triple deformity of the knee. And what are the components of this triple deformity? So first you will see the flexion, then you see the posterior subluxation, and then you see the internal rotation of the tibia. So there will be rotation, that is the external rotation of tibia, right? So the tibia is externally rotated, the leg is externally rotated with posterior subluxation and the flexion. So this is the triple deformity of knee which is seen in tuberculosis. So with this bit, we have to again read about what is the condition where you see the triple deformity. So here you have to remember only the mnemonic triple to remember where you see this triple deformity of knee. So this can be also a potential question. So what is T stands for? Tuberculosis, as we have already discussed. Then R is for rheumatoid arthritis. So R is for rheumatoid arthritis, and then I is for your iliotibial contracture, and P is for polio. These two for low clotting factors, and this is hemophilia. So because we have 5, so it is easy for the examiner to put 4 in that, right? So you have to remember where you see this triple deformity of knee and what are other conditions which will result in triple deformity of knee. Yes, so this is the triple deformity. Please remember this mnemonic and please remember these conditions. This is also a potential exam question. So having understood so much about your TB, so we have already completed the discussion on TB. So let us answer this. What is the most common affected area? So as you've all answered, the one, that is acetabulum, is the area where you see the TB most commonly involved. And then this is your femoral head. And then this is your trochanter, that is your greater trochanter. And then you have your lesser trochanter, right? And where is this Babcock's triangle? Somewhere here. So this is the area of the Babcock's triangle. So subcapital area, anterior posterior region, this is your Babcock's triangle. So this is the area where TB can also be seen. So this is everything about the TB. I hope I have completed all those important questionnaire which might be asked in your exams, right? So now let's go on to the next question. So here the question is about a 49-year-old male with the lesion involving the epiphyseal region of lower end of the femur. Right? The multinucleated giant cells and the mononuclear cells can be seen in the histopathology. What is the probable diagnosis? So I think it is most easiest question, right? I hope everybody will answer this. And if you see there is involvement of epiphysis, there are only 2 conditions. One is your giant cell tumor. The second one is your chondroblastoma, right? So giant cell tumor and chondroblastoma, these 2 are only things which should flash on your mind whenever you see this epiphyseal region. Okay, so whenever you see this epiphysis region, please remember these are 2 important conditions, giant cell tumor and chondroblastoma. And just I want to add one more, that is clear cell chondrosarcoma. Right, so this is an addition for people who want to remember more and score more. So this is for clear cell chondrosarcoma, which is also seen in epiphysis, right? So these 3 conditions are seen mostly in the epiphysis. And there is one more clue in the question, that is the biopsy showing your giant cells. So whenever you see a giant cells on histopathological examination, that is on biopsy, it is a confirmed diagnosis of giant cell tumor. But only thing which I feel is not fitting in GCT is the age. right? Usually it is seen in the third decade, right? 30 to 40 years. It is somewhere in the 50 years, which the question is asking. But other everything, the epiphyseal region, the giant cell, the mononuclear cells, everything is fitting for GCT. Now let us see the other options. So UBC, so unicameral bone cyst. So here what you see is a single area where you see unicameral bone cyst. And what is the what this is a cyst like condition, like this is a tumor like condition, a cyst, which is seen in mainly in the humerus, and this is mainly seen in the metaphyseal region. So you usually see this unicameral bone cyst in the metaphysis. And what is the sign which you see here? Fallen leaf sign. So fallen leaf sign, where, or the trap door sign, you see this in case of UBC, where you see a pathological fracture associated with the UBC. So whenever there is a pathological fracture, you see on the X-ray, and you see a radiolucent area, right? And this is an indication of the cyst. And then there is a pathological fracture, and then you see a small fragment which is seen inside, that is called the fallen leaf sign or the trapdoor sign in UBC. Next comes your ABC. It is somewhat aggressive, right? It is somewhat aggressive, the aneurysmal bone cyst, and it is filled with blood. And whenever you see a cyst with the fluid levels, right? So there are fluid levels. This is called the ABC. Again, it is seen in case of metaphysis, and you take the MRI, you see what is called the loculated areas, or there are septa, and there are fluid fill density, fluid filled levels, right? Fluid filled, yeah, blood filled, fallen leaf sign. Very good, Abilo medicine. It is fallen leaf sign and blood filled with septa in case of ABC, right? Now we'll see about osteosarcoma. Osteosarcoma, again, it is a metaphyseal region which is involved, and this is the malignant tumor. So ABC, so UBC and ABC are somewhat tumor like conditions, right? And but here this is malignant condition, where this is a osteoid forming tumor. So here you see the osteoid forming, that is the bone forming. So what are those X-ray appearances? The most important are the sun ray appearance and your Codman's triangle. Yeah, sunburst appearance or sun ray appearance, and then your Codman's triangle. Right, so these two are important things which you see on the osteosarcoma. It is mainly seen in the metaphyseal region, and here the most important thing where it is seen in femur, that is lower end of femur followed by tibia. Right, so this is about the few tumorous conditions which are generally asked. So GCT is most important, no doubt about it. Next comes your osteosarcoma, next comes your ABC. So these three are most important topics, right? You have to at least understand about these three before the day of the exam, right? So that completes our question. Now let's go to the next one. A 33-year female has a backache going to the right lower limb. So here there is right side lower limb which is involved, and the following is the MRI. What is the most common nerve root involved? This we have already discussed it yesterday. So all you have followed yesterday's class, I think they will be answering it as a very easy question. So for this, I will just help you naming the numbers. So this is your S1. Is your L5, L4, L3, L2. So somewhere here you have seen this disc degeneration. Yes, very good. Yes, Saini and Med Psycho. So L4 and L5 is the region which is involved. So L4, L5, this is the disc, and there is a right lower limb involvement here. So the answer would be L5, because yesterday, if you remember, the vertebrae, right? So these are the vertebrae, and here the nerves, right? Something like this, the exiting nerve root, the traversing nerve root, right? So the exiting, if this is L2, L3, L4 and L5. So just this will be the two nerve root, this will be the L3 nerve root, and this will be the L4 nerve root and L5 nerve root. So whatever is the nerve which is passing will be just below the level of that particular vertebrae. So if you take L4 and L5, L5 is the nerve root which is involved because this is the nerve root which is traversing, right? So this is the traversing nerve root, and here this is the disc. So disc will usually affect this part. So this part is affected here. So this might be the right side, this might be the left side. So if it is a central type of disc prolapse, usually it is the L5, but sometimes if there is a lateral disc which is obstructing the foramina, it could be L4 also. So this also you should put in mind. Usually they will ask about the central disc. If nothing is mentioned, it is central disc, then it is L5. But sometimes if it is a lateral type of disc which is involving the foramina, so from the foramina it will be L4 which is exiting, right? So this could be L4 and L5. The two nerves can be involved depending upon the question. So here usually if nothing is mentioned, we will take this as central disc, and if it is a central disc involvement, it is L5. So the answer would be L5. So that was the answer for that. Now the next question. A 39-year-old patient from Bihar comes from generalized, so they are mentioning something about the area, and then there is a generalized bone pain diagnosed to have fluorosis. So usually this fluorosis is epidemic, right? It is an endemic. So it is restricted to particular area because of the water fluorosis, right? Because of the presence of fluoride in the water. So now let's deal about fluorosis. So usually this fluorosis is endemic, and what is the area? Usually seen in the Bihar region, and coming to the south in Bihar region, and coming to the south, it is the area called Nalgonda. So where you see excessive cases of fluorosis. So what is this fluorosis? So fluorosis is a condition where you see the bone has been completely, it is now, if you remember, the bone is formed by calcium phosphate, right? So calcium and phosphate are two important things which you see in case of the bone. Now this phosphate is replaced by fluoride and it forms calcium fluoride, and this causes ossification. This causes ossification of the ligaments, and here the bone which is formed will be very hard, right? So this will become very hard, and now this loses its elasticity, and because of this it will result in what is called as pathological fractures, right? It will show with pathological fractures and deformities. And here there is one more extraskeletal manifestation, that is the dental fluorosis. You will see the dental fluorosis, and where there is yellow color discoloration of the teeth. So whenever you see a patient with yellow color discoloration of the teeth and generalized bone pains, you have to always order for serum fluoride or urine fluoride. So urine fluoride is most consistent investigation and confirmation than serum fluoride. So here in this case of fluorosis, what you see is the osteosclerosis. So osteosclerosis is the one which you see in case of fluorosis. So many of them answered as B. So L4, L5, if you're answering for the previous question, that is right. But this particular question, that is fluorosis, the answer is osteosclerosis. So osteosclerosis is, yeah, how to treat, we'll see. So osteosclerosis is the thing where you see the entire whatever the bone is there will be excessive amount of bone formation. So this excessive amount of bone formation is called osteosclerosis, where the bone becomes very hard and loses all its elasticity. And one more thing is the ligaments will get ossified, and this condition is mainly seen in case of spine. So spine, you will see the fluorosis where there is a ligamentum flavum hypertrophy, right? and this will lead to lumbar canal stenosis. So you will see conditions where the stenosis of this fluorosis and this so after you measure the fluoride levels, you will see that there is elevation of the urine fluoride in patients suffering from this lumbar canal stenosis in case of people living in this endemic regions. So first, how should you treat it? You have to always treat, first you have to treat the water which is there, and this is been discovered as Nalgonda technique, where the fluoride, whatever the fluoride content is there, you first remove entire fluoride content and you make water which is less content of fluoride. So permissible level of fluoride content, you bring it to permissible levels. So first, and once the patient has been affected with fluorosis, there is no treatment as such treatment where you can give, but sometimes you can give the chelating agents which might interfere with that formation of calcium fluoride, right? And then you treat, if there is a dental fluorosis, you treat the whitening procedures you do, and if the patient present with stenosis or hypertrophy, you take up with the laminectomies and the ligamentum flavum hypertrophy if it is there, and you will relieve it by decompression. So as such, treating of the fluorosis is mainly you have to treat the basic water level. So that is by the techniques which we use. And here from orthopedic side, you increase the calcium supplementation and you increase the vitamin D supplementation to the patient. And then if the patient is suffering from any established fluorostic conditions like lumbar canal stenosis, you go for decompression, and sometimes you may treat with the chelating agents too. Fine. So that is the answer for this. And I have forgot to tell that the TB hip biopsy. So sometimes whenever you have this TB hip, usually we treat them with the help of the clinical condition. So in case of TB hip, I'm just going back to this answering this Avilo Medicine's question. So he have answered it. He have asked me a question whether this biopsy is needed for TB hip and how to take a sample in the hip, right? So for that, my answer would be you can take biopsy. Always a biopsy is the confirmation of the TB hip. So you will do it maybe with the percutaneous techniques, or you can go open where you have to give the joint wash for joint debridement. For example, if the patient is coming in the early stages, you can give a joint wash. So you have to open the joint and give complete thorough wash to the joint, and you can take a bit of sample and send it to histopathological examination. And you can take even sample by ultrasound techniques or CT based techniques, where percutaneously you will take the biopsy sample and send it to HPE. Right, the procedure of the sampling is not very important to you, and this is not the scope for answering that question. So the next question is, identify the following brace which is used for this condition. So what is this brace? So this brace is called the Pavlik harness. So I've already given a clue, the type of the brace. So I've already identified the brace for you, and I'm just waiting for you all to answer for which condition is this Pavlik harness used. So I think most of you know what is the answer for it. The Perthes disease, or the slipped capital femoral epiphysis, or the congenital coxa-vara, or the DDH. So DDH here is the congenital developmental dysplasia. So what would be the answer? So the answer for this is your DDH. So DDH we have discussed yesterday. So this is developmental dysplasia, mostly seen in the Western countries, right? It is mostly seen in the Western countries. And what are those risk factors? So first, baby, then your female child, then usually the breech presentation, right? So all these are the risk factors for the baby to be a DDH baby. So usually firstborn females with breech presentation are mainly at risk for developing this condition called DDH, right? And in this DDH, what will happen? The head and acetabulum are underdeveloped. They are underdeveloped, not fully developed, right? And because of this, you will see what are all the deformities which we are able to see in the later stages while the baby is walking, right? So the head usually gets dislocated, so there will always be a dislocation of the hip, right? And what is the screening tests for DDH? This is very important. The screening test for DDH. The screening test for DDH. Screening test is Barlow's and Otterloni. So these two are important screening tests which are done on the newborns, and then there is an ultrasound which is done, because less than 1 year of age you cannot see the cartilage because still the head is in the cartilaginous stage. So usually on the X-ray it is not that visible, and now you go for ultrasound, and the ultrasound you have two different angles called alpha and beta angles, and based upon this alpha and the beta angles you will explain the grades of the DDH, whether it is present in grade 1, grade 2, grade 4, right? And this Barlow's and Otterloni, you already know that Barlow is bringing the hip outside and Otterloni is putting back into it. So whenever we are able to displace the hip joint, that is the femur head, in and out, that means the baby is suffering from DDH. So that is developmental dysplasia of hip. If you have identified this less than 6 months, so as usual, if the patient is brought to you before 6 months, you can treat it with splint. We can treat it with splints. So there are two types of splints which can be used, that is the Pavlik harness, and then is your Von Rosen splint. And then there is also hip spica for people more than 1 year up to 3 years, where you can do the open reduction or the closed reduction, and then you will put this hip spica. But if it's less than 6 months, you can go for splinting, and there are two types of spinking. There are two types of splints which we use. Barlow is Barlow. So here this is Pavlik harness used for DDH. And what is Perthes disease? Perthes disease, please remember that Perthes, the age gap is mainly the 4 to 8 years. So usually we see this is because of the decrease in the blood supply. There will be femoral head, that is femoral head becomes necrosed, right? So there will be necrosis of this femoral head, that is called Perthes disease. And there you do what is called the containment procedures, that is you want to put the head inside the acetabulum. So there you go for containment procedures, right? That is Perthes age group you have to remember as 4 to 8 years. Slipped capital femoral epiphysis is, so this is called as SCFE. So this is usually, remember the clue. So for identifying SCFE, it is usually the males who are very fat with endocrine abnormalities, right? Endocrine abnormalities, and the age group is 10 to 14 years. So you will see the question starts as a male child of some around 10 to 14 years, like 10 years, 12 years, 13 years, 14 years, in the teenage before attaining its puberty, and then with some endocrine abnormality, with a trivial trauma. He presents to you with the pain in the hip, or sometimes, be careful, there might be pain in the knee joint. So there will be a pain in the knee joint. Because from the hip, the pain is referred to the knee joint. So there will be pain in the knee joint for case of SCFE. So these are all the terminologies you have to search in the question to identify it as SCFE. Right? In DDH, it will be a newborn baby. Maybe on screening they have identified it, or on ultrasound they have identified it. But if the patient attains the age of walking, then you can see certain signs where the thigh folds, and then you have increased thigh folds on the area, or you will see shortening, and you see this Trendelenburg test, which is positive, right? And then you see what is called as Allen's sign. So these are all you see in case of your DDH, when the baby is in the stage of walking. So there will be increased thigh folds, the buttock will be at a lower level, there will be a Trendelenburg test which is positive, and this shortening is seen. So these are all the things you have to identify. And if this DDH baby is reaching stage of somewhere in their adolescent stage, then you see what is called as increased lumbar lordosis. So there will be increased lumbar lordosis or exaggerated lumbar lordosis because of the hip abnormality and their walking style. So there will be waddling gait. If both the hips are involved, there will be waddling gait, right? So that is how you have to identify from the question. In case of DDH and Skiffy, you have all these things, and for Perthes, it is mainly the patient will present with pain in the hip joint, and sometimes it could be painless, and the age is 4 to 8 years. So these are the clues which you have to look for the exam, which you have to look for identifying the questions or answering the question, right? So this is about the this particular question where they have given an image of pelvic hernias, and this brace is being used in case of DDH, right? Now the next question. The next question is, a child is unable to carry out movements of pronation and supination since childhood. So here the clue here for us is since childhood. That means it is a condition which has started very early, right? Now he is unable to carry out movements of pronation and supination. So something related to the forearm since the childhood. So here there is a radial dislocation, or is it a congenital radial head dysplasia? Then there is a radio-ulnar synostosis or elbow dislocation. So let us try to answer this question. So let us see the image first. If you see the image, now this is the humerus which you can see, and you have ulna, right? And this side you have radius, right? So this is the bones which we have identified it. And if you see this area which is a gap between the radius and ulna, it is called the interosseous membrane. So this membrane is seen as a gap between the radius and ulna. So whenever you see this gap should be equal, right? If you see, the gap is completely seen here, but here it is absent. So why it is absent? Because it is filled with bone. You can see an area of sclerosis in the upper part, or the upper area, that is the proximal radio-ulnar area, right? So let us understand that you have known nothing about this question. So you only know that supination is pronation occurring forearm, right? So they have put an X-ray for the forearm. Now let us understand this X-ray. So first one is radial head dislocation. So this is the radial head here. So this is the radial head here, right? So radial head here. And then there is a congenital radial head dysplasia and radio-ulnar synostosis and elbow dislocation. So this is not elbow dislocation, it's very much clear from the X-ray itself, and it could be congenital radial head dysplasia or radio-ulnar stenosis according to this image. But you already know what is synostosis. Syn means fusion, ostosis means formation of bone. So because of the formation of bone between radius and ulna, you cannot perform this action of pronation and supination, because the pronation and supination requires what joints? So pronation and supination is done in the forearm with the help of your radio-ulnar joints. So there should be a proximal radio-ulnar joint and a distal radio-ulnar joint. So whenever these two joints are normal, then you do what is called the pronation and supination. So this is pronation, this is supination, right? And here if you see, there is some amount of sclerosis which is formed between radius and ulna. So this is an classical example of your radio-ulnar stenosis. So this is the answer, that is the radio-ulnar synostosis, right? And elbow dislocation is usually where the you see in the olecranon is getting displaced. So this could be anterior or posterior dislocation, so which is not seen on the X-ray. And this radial head dislocation, so whenever there is a radial head dislocation, that is also seen mainly on the lateral X-ray. You will see this on the lateral X-ray, right? And on the lateral X-ray, you have to just identify the you see it on the AP view, and this is mostly associated with your Monteggia fracture. Monteggia fracture, where you see the proximal ulna fracture with the radial head dislocation, right? Radial head dislocation. And if it was radial head dysplasia, so this inostosis, this whatever the ossification is not seen on the x-ray. So because of this, we have answered it as the radio-ulnar synostosis. So that is the answer for the question. Now let's go to the next one. So here there is a 7-year-old child. He is suspected with a supracondylar fracture of the right hand, complaining of pain and swelling. The X-ray of the right elbow was not significant. What is the next best step in this case? So this is a bit a tricky question. So let us now deal it in detail. So here the age is 7-year-old, right? So that means you need to actually get an opposite X-ray. So usually in case of pediatric conditions, we usually ask for both the sides X-ray. That is bilateral limbs. We use X-ray because we need to compare it. Because if you remember the elbow which is there, they will have the ossification centers, and all these will be fused by the age of 16 or 18 years. So you might be confused because of this non-fusion of this cartilage. Sometimes you may take this as fracture. So you always need the opposite X-ray for comparison, especially in case of childhood. So here when you start the question with child, you have to always put in mind that they should be opposite X-ray. With the supracondylar fractures, there is a suspicion of the supracondylar fracture. The X-ray was not significant. So similarly, once you take the clinical history and you put up the clinical diagnosis of supracondylar fracture, and now then you order for an X-ray, and if in this X-ray you don't see any fracture, then the next best step what you have to do is always compare it. That is the next best step. There is no doubt about it. So if that step is not done, that is the next best step. But if this step is already done, then you have to always go with the slab. So here in case of orthopedics, we always over treat the patient. That means we treat the patient with the slab, we give them little support, and now you do again the X-ray after maybe 1 week or 2 weeks just to confirm it, right? So even 1 week or 2 weeks just to confirm the fracture. If you now find the fracture, that is well and good. But if you still don't find the fracture after 2 weeks of immobilization, then you can be assured that there is no fracture, and then you can remove the slab and reassure the patient that everything is normal. But for the first time when you see the X-ray which you don't see any abnormality and still you think that there is some problem, you have to always immobilize the joint, right? So these two hold good. One in case of supracondylar, in case of children. The next area where you have to be suspicion is your scaphoid fracture. So here this is one of the most important notorious scaphoid fracture where we might miss in the first examination. Even the X-ray should deceive us, can be deceiving to us. So that is why you have to explain the patient, and then you have to immobilize in the cast or slab. And then after 2 weeks, you have to again take the X-ray. So now after 2 weeks, still you find that X-ray is normal, then you can be assured that there is no abnormality in the bone, and you can even send the patient happily, right? So here the next best step is always compare it with the left hand. If this step is also done, then you will do slab. Then you will go for closed reduction and slab, right? And now if you see that there is some amount of displacement, then you go with closed reduction with K-wire fixation, right? So closed reduction and K-wire fixation. Or if your this casing is done after your K-wire fixation. So K-wire fixation, and then you go for casing. So that is the steps where we follow for supracondylar fracture. So once the patient is arrived, you will thoroughly examine, you will take the X-ray, both the sides to compare, and when you see somewhere which is undisplaced or it is mild displacement where you can reduce it easily, so you confirm it on the X-ray again, and then you put a slab and leave. Or if you see there is a displacement is seen, then you do a closed reduction and then put a K-wire, right? So K-wire will give the strength to the fracture. Or if you see a gross displacement, then you go for an open reduction plus a K-wire fixation. After K-wire, you go for casing. So this is how you treat a supracondylar fracture humerus, right? So we are talking about the supracondylar fracture humerus. Okay, so that is the answer for this question. So next, a 28-year-old patient presented with the following serum parameters, which is a normal serum ALP, normal PTH, increased calcium and increased phosphate. So here for any metabolic disorder, first you have to look for calcium, then phosphate, then your vitamin D, then your parathormone, and ultimately your alkaline phosphatase. So these are certain important parameters which will land or help you in the final diagnosis. So here the question was, there was an increased calcium and phosphate, but there was normal ALP and a normal PTH, right? So let us put this. So here there is an increased calcium and there is an increased phosphate, but there is a normal PTH and a normal ALP. There is no mention about your vitamin D, right? So here whenever there is so let us look at the options first. So vitamin D toxicity, we'll just put this as a question mark. Then we'll go for hyperparathyroidism. So the name itself is telling hyperparathyroidism. So there should be an increase of parathormone. So here whenever there is an increase of parathormone, there is always increase of calcium. But you have to remember that parathormone and phosphorus are not friends. So P and P, like poles, repel, right? So they should always be a decreased phosphorus in case of your PTH, right? Whenever there is an increase in PTH, there will be increase in calcium, because parathormone will always cause an increase in calcium, but there will be a decrease in the phosphate. So it is this is the dictum for parathormone. So here there was an increased phosphate, so this is not the answer, right? So this is not the answer. Then osteoporosis. So osteoporosis, so there will be normal parathormone, normal ALP, but they will be normal or decreased calcium, but they will not be increased calcium, right? So this is also not the answer. Then osteomalacia. Osteomalacia is nothing again, but there is a decreased vitamin D in case of adults, right? In case of children, it is rickets, but in case of adults, it is osteomalacia, where you see a decrease in vitamin D. So whenever there is a decrease in vitamin D, there will be a decrease in calcium, and then there will be decrease in phosphate also, because vitamin D plays an important role in absorption of calcium and phosphate. But here the question was increased calcium and increased phosphate. So undoubtedly the answer here is vitamin D toxicity, but unfortunately, there was no mention of vitamin D, which would have made our answer even more easier. So that is the method you have to always follow for answering the metabolic disorders. First you have to write which is increased, which is decreased, and then accordingly you have to answer. Please remember, take at least a little time more than other questions to answer for metabolic disorders, because always there will be little confusion of increased calcium, increased phosphate, increased parathormone, decreased ALP, and you need to read it carefully, you need to write it on a paper just for the clarity, and then you answer this question. So this is my way of doing metabolic disorders questions, right? Hope you have all understood how to deal with them, right? Now let's go to the next question. So the next question is treatment of olecranon fracture as seen in the image. So olecranon is one more important area. Why? Because there is an attachment of a tendon, that is your triceps tendon. So there is a triceps tendon which is attached to it. So similarly like your patella. So yesterday in the class we have discussed that patella. So there is a patella, because of the pull of the tendons. Usually these patella bones will not heal properly if they are left like that. If they are left untreated, because of the pull, they will be non-union. Similarly in the olecranon, there is a triceps tendon, so that will also pull the fragment upwards, right? It will also pull the fragments, hence hindering the union. So for this, again in the olecranon, what you do, because of this fracture is there, so you can identify that there is an olecranon fracture. And here mostly the olecranon fractures are treated again with the tension band principle, that is the tension band wiring. So tension band wiring is usually done as an open reduction procedure. You can't do a closed reduction TBW. So TBW is nothing but you take two fragments like this and then you join them. So there are two fragments, right? So upper fragment in case of patella, and then you join it and fix it in the figure of 8. So for this you need to open the bone and then attach it, similarly like the olecranon. So it is always open reduction with tension band wiring, so that will eliminate this option. And it is always above elbow plaster, so below elbow there is no role, so these two have been omitted. Now you have to decide between above elbow plaster slab or open reduction with TBW, but you already know that there is one tendon which is constantly pulling the fragment, so to be sure for the union you go for open reduction with tension band wiring. So this is a very good below, this is an avulsion fracture, so here you always go for open reduction with tension band wiring, right? So that is the treatment, and this TBW is also one of the favorite questions for the examiners. So usually they put up this X-ray of patella or the olecranon and will ask you what is the treatment for it, or sometimes they will put up they will put the TBW image itself and will ask you what is this image. So just revise this tension band wiring before the exam day so that it will be easy for you to answer, right? So that is about the question. Now the next one, the diagnosis of the gout is confirmed by which of the following tests? So for that you have to always know what is gout. So I know all my students are very well versed with the gout, where there is an increased uric acid levels and these will enter into the joint, and now they are saturated and they are deposited in the form of crystals. So these are called uric acid crystals. So this is a crystal disease, crystal joint disease, uric acid crystals which are present in the joint, and this will inflame, this will start the process of inflammation, and now they will cause joint arthritis, right? So now here the gout, the most important thing is it will affect the first MTP in the foot, right? So this is called as podagra. And then where the question usually will be males with alcohol. So these are the clues. So there will be male, there will be alcohol in the question, there will be first MTP, and then you will have to answer it as uric acid crystal. So they might ask you what are these crystals, what are the they can also club with the biochemistry and ask them what is the nature of these crystals. So this is about the uric acid crystals, that males and alcohol, but sometimes they may also put as females on diuretics. So this is the important thing which I want my students to remember, because male and alcohol is everybody knows, right? Now they may shift to females with the diuretics, or females with renal disorder where you can't eliminate the uric acid out of the body. So now this uric acid will become more in the blood and now it gets deposited in the joints, and now they complain again with the first MTP, right? So here the answer again will be the gout, right? Monosodium urate crystals. So that uric acid are nothing but in the form of monosodium urate crystals. Monosodium urate crystals, and here you will see as increased uric acid levels in the blood, right? And now to confirm this, you will do what is called as knee joint aspiration or synovial fluid aspiration, and then you do put them under the polarized light, and then these crystals you identify and then put on polarized light and birefringent crystals. So these are negatively birefringent. So negatively birefringent crystals. So they will appear green color. So these are all the things which you have to look for gout. So they are negatively birefringent, polarized light, and you have the friend of uric acid, that is CPPD, right? So this is CPPD, where usually involving the larger joints, that is your knee joint are mostly involved, right? So this is also one more thing where you see positive birefringent. on polarized right. So this is calcium phosphate deposition, calcium pyrophosphate disease. So here that is, yeah, negatively birefringent. Very good, Avilo medicine. Yeah, there are needle shaped. So that is about the uric acid, and here the diagnosis of the gout is confirmed by your synovial fluid analysis. So this you take as the confirmation. So this gout you see needle shape, but CPPD are rhomboid shape. These two are the shapes. So this is how they make it integrated syllabus, right? So now they might ask you what are these crystals. So they are monosodium urate crystals. They are negatively birefringent on the polarized light, and they are needle shaped. When you see CPPD, this is positive refringent, birefringent, and then they are rhomboid shaped crystals, right? So the confirmation of this gout is mainly by synovial fluid analysis, but usually clinical diagnosis we do it with increased serum uric acid levels, right? Serum uric acid levels. And X-ray, again you will see certain changes. You have to remember about the G sign or the spur sign, which is seen on the gout X-ray, right? So that is about the crystalline deposition diseases. So now the next one, identify the given X-ray. So just they have put up with the X-ray which is showing the ankle joint. So this is the ankle joint X-ray, and you can see there is a fibula where there is a huge amount of the sclerosis, right? Because you can see more of why that is nothing but bone, and this bone arrangement is in shape of your sunburst appearance. Sunburst appearance. Sunburst appearance. So sunburst appearance, we have just dealt with that, and here the answer is osteosarcoma, right? Very good. Osteosarcoma is the answer, where the sunburst appearance or the Codman's triangle is seen in case of osteosarcoma. Then Ewing's sarcoma and osteoid osteoma and osteochondroma. So osteochondroma is a type of benign disease. Yeah, this is a periosteal reaction. Sunburst appearance is a periosteal reaction. Periosteal reaction, yeah. Very good. This is periosteal reaction along the Sharpie's fibers, that is your osteosarcoma. Sometimes they will even claim that it is along the blood vessels too. So Sharpie's fiber is the first best answer. Next is your blood vessel. So anywhere formation along the Sharpie's fibers or the blood vessels, they take up the shape of your sunburst appearance. So that is the osteosarcoma. Very good. Now let's deal with the options as well, so that we can get more familiar with the other topics, right? So first, coming to the osteochondroma. So osteochondroma, it is again a benign disease. So it is a benign type of disease, usually seen in the metaphysis, right? Seen in the metaphysis, and you can see something like the cartilaginous cap with the bone stalk, right? So bone stalk, that is called the peduncle. So it is pedunculated, and there are two varieties. It could be pedunculated, it could be sessile. It is seen in metaphysis. Usually it is seen below it is seen near the growth plate, right? So it is seen near the growth plate, and it is away from the joint, growing away from the joint. That means if this is the joint, you can see somewhere near the growth plate, that is, this is the bone stalk, and now you see the cartilaginous cap here. So this is your osteochondroma. It is going away from the joint, right? So this is seen in the metaphyseal region. Okay, now usually for osteochondroma, you can just wait, or sometimes you can excise this osteochondroma, excision, and sometimes they cause complications, such as they will cause bursitis, which will irritate the bursa which is present there, or they can cause compression of the nerves or the vessels. So here, whenever there is this complication, you immediately excise this osteochondroma. So that is about osteochondroma. Then coming to the Ewing's sarcoma. So what is Ewing's sarcoma? Ewing's sarcoma is a malignant disease. So this is a malignant type of disease, where it arises from the neuroectodermal cells, right? So there is neuroectodermal cells involvement, and here Ewing sarcoma is mainly seen in the diaphysis. You will see the onion peel appearance. So you will see what is called as onion peel appearance, where the periosteal reaction is seen in laminated fashion. So you will see what is called as this laminated appearance. So here the periosteal is formed like this. So this is something like your onion, right? Yeah, exostosis is another name for osteochondroma. Now here the periosteal reaction. So this is the onion peel appearance in case of Ewing sarcoma. But what you have to be careful in Ewing sarcoma is it can mimic like a infection, that is osteomyelitis. So here you will also have raised ESR, raised CBP, right? All these things will be seen, along with the patient will present with fever. So these are all there. So whenever a baby or a child will present with the fever, with raised ESR, raised CBP, you have to always be careful that you are not dealing with Ewing sarcoma, because the presentation will be similar. It will mimic the acute osteomyelitis, right? And the one thing which can be differentiating is sometimes the acute osteomyelitis starts with metaphysis and this is the diaphysis. So that would be one differentiating feature. But always remember, whenever you're dealing with acute osteomyelitis where you see raised ESR, raised fever and not reducing with the antibiotics, then you have to always put Ewing sarcoma in mind. For that you have to always culture and biopsy the samples. So whatever samples you take, you have to send them for culture and send them for biopsy to be double sure of what you're dealing with, right? So that is about the Ewing sarcoma and osteochondroma. And the osteoid osteoma. Osteoid osteoma. So here, this is the important thing about osteoid osteoma is, again, it is seen in the diaphyseal region, right? And here it will respond to NSAIDs, that is aspirin. So there is an aspirin test for this. So usually the patient complains about pain and this pain is relieved with aspirin or NSAIDs. So whenever this pain is relieved, you confirm this as osteoid osteoma, right? So that is about the important points regarding all those tumorous conditions, right? Now the next question. A 90-year-old boy was riding a bicycle. He fell down forward and an injury to his shoulder was seen. So this is the X-ray they have put up. And now this X-ray, if you see that the glenoid is empty, right? Whenever there is glenoid empty and you see something away from the glenoid, this is nothing. Yeah, night pain is relieved with aspirin. Yeah, correct. This is empty glenoid. This is a condition of dislocation. So shoulder dislocation. So anterior dislocation is most common in case of shoulder, and whenever there is an anterior dislocation, there will be damage to the nerve, that is the axillary nerve. Very good. So the axillary nerve is most commonly involved in shoulder dislocations. This also we have discussed yesterday. So posterior dislocation of hip will cause the problem to sciatic nerve. Anterior dislocation of the shoulder will cause the problem or the injury to the axillary nerve. So the answer here is your axillary nerve, right? So very good. So then where is your ulnar nerve involved? So ulnar nerve, yeah, axillary will supply. Axillary nerve supplies what? Deltoid and teres minor. So the supply is for deltoid and teres minor. So deltoid also supplies a little bit of sensory region where near the shoulder. So that is called the regimental badge area, right? Regimental badge area. So here ulnar nerve is involved in which bone or what? Where is this ulnar nerve involvement? Ulnar nerve, whenever you see any problem with the medial condyle or medial epicondyle fractures, then you have to be careful for ulnar nerve injuries. So ulnar nerve, and then radial nerve. This all is very easy, right? Radial nerve is mainly in the humerus fracture, right? Humerus fracture, that is also shaft of humerus fracture. Whenever there is a shaft humerus fracture, yesterday we have dealt with this. So there is a radial groove which is present on the posterior aspect of the humerus, and then the junction of the distal middle third is your Holstein-Lewis fracture, that is the radial nerve involvement. And axillary nerve is mainly involved in the shoulder dislocation. And then coming to the median nerve. So median nerve is mainly related to tunnel, that is your carpal tunnel syndrome. So whenever there is a tunnel syndrome or paresthesias which are present in the 3.5 fingers, that is your thumb and 2 index and the middle finger, then it is your carpal tunnel syndrome and there is involvement of your median nerve, right? So this is the median nerve. That is how the nerve and their injuries are also very important topic. Okay, next question. Miss Neetha, who is a postmenopausal woman, fell down in the washroom. What is the most common fracture she might suffer? So the most common fracture, who is a postmenopausal woman, that is the only clue we have here. So postmenopausal woman who is a slip and fall. So fell down in the washroom is nothing but a trivial trauma, right? So there's a slip and a fall type of trauma. So this trauma usually in case of postmenopausal women will result in the Colles fracture. So if you remember yesterday also we dealt with Colles fracture, that is it is occurring in the postmenopausal woman in the corticocancellous junction, right, and with the specific displacement. So what are those displacements? The dorsal displacement, the dorsal tilt, right, and then you have your supination. So all those specific displacements which have been described by the Colles fracture. So that is the Colles fracture. So Colles is, again you have to remember, at the corticocancellous junction, which is just 2 centimeters from the joint, because in the postmenopausal woman, and this is also sometimes considered as an osteoporotic fracture. So vertebrae first, then the Colles, that is the distal radius. The most common area which is involved is your distal radius fracture, right? And then you have your hip fracture. So these three are considered as the patient suffering with osteoporosis, the most common fracture seen in patients suffering with osteoporosis, that is the postmenopausal woman. So here you see Colles, and Colles you have specific displacements, right? So that is supination, then you have impaction, and then you have dorsal tilt, then you have dorsal displacement, right, and then you have lateral tilt and the lateral displacement, and the lateral displacement. So these are the specific displacements which you have to remember for Colles. It is not just the corticocancellous junction with the specific displacements. So Vijay short, that is what I'm telling. Whenever these displacements you see, then it is called Colles. Then what is Smith's fracture? So we are coming to that particular question. Smith is reverse of Colles, where you see the ventral displacement or ventral tilt or the ventral displacement, right? That is ventral or palmar displacement or palmar tilt, which is seen in case of Colles. So that is the opposite side of the Colles. So Smith's fracture is this palmar tilt or palmar displacement. So this is dorsal tilt, that is palmar tilt. So opposite of Colles is your Smith's fracture. So if you see here the dorsal, there is a dorsal displacement, right? So here the distal fragment will come to the dorsal displacement. It is moving this side. So similarly, this is called the Colles. So if it goes on the opposite side, that is ventral side or the palmar side, then it is called the Smith fracture, right? So Colles fracture is the Colles fracture is usually treated with reduction. So there are specific reductions maneuver which you have to follow. So first you give traction, the longitudinal traction, then you disimpact the fragments, then you do palmar flexion and ulnar deviation. So this is what again you have to remember. So there is palmar flexion and the ulnar deviation. So this is how you reduce the Colles fracture, and after reduction you put them in casing. So you do a below elbow casing and you protect the fracture. So this is the Colles, and the common complication of Colles is malunion. So whenever there is malunion, it goes into deformity. This is called the dinner fork deformity. This also we have discussed it yesterday. So there is dinner fork deformity in case of Colles fracture, and here you will have what is called as a garden spade deformity. This is seen in case of your Smith's fracture. So there is palmar tilt or palmar displacement, that is the Smith's fracture, that is Gardner's deformity. Very good. So that completes the topic on your fractures. So Monteggia and Galeazzi, we have already dealt with Monteggia, that is the proximal ulna with the proximal radial head dislocation, right? So M for M, so medial, that is ulna bone, so there will be ulna fracture plus proximal radio ulnar joint, that is radial head dislocation for Monteggia. Then for Galeazzi, you have distal radius fracture, distal radius plus distal radio ulnar joint dislocation is Galeazzi fracture. So please remember Monteggia and Galeazzi, there are very important questions and usually they have asked every time in the exam. So they might be put up Monteggia and ask what is this type of fracture, and similarly Coley's, Smith's, Monteggia, Galeazzi and Barton's. What is Barton's? We have discussed this also yesterday, that is the intra-articular extension of the distal radius fracture is your Barton's. Barton's can be a volar Barton or a dorsal Barton fracture, right? Next question. A 26-year-old football player with a knee injury diagnosed as medial collateral ligament injury. Which structure is most commonly associated with this type of injury? So I hope you are also very familiar with the sports medicine. So let's deal little about the sports medicine. So in case of sports medicine, the most common thing they ask you about the knee joint, and in the knee joint you have to be thorough with the ligament injuries, right? And these ligaments are first your ACL, then your PCL, then your MCL, the LCL. So these are the important ligaments, and then you have meniscus, that is your medial meniscus and the lateral meniscus. So ACL and MCL usually, so on the medial side, injuries are common, and the most common one among all is your medial meniscus. And then comes your ACL and then your MCL. So this will occur whenever you have the valgus plus your hyperextension injuries, right? Your hyperextension injuries, and this has given a specific name called O'Donoghue unhappy triad, right? So this is what you have to remember: the medial meniscus with the ACL with the MCL in case of your valgus plus hyperextension injuries will present with you this triad, the O'Donoghue triad, that is your O'Donoghue unhappy triad, right? And coming to the sports injuries, they always test you about the tests which are associated with this ligament. So ACL, whenever it is ACL, there is an anterior drawers test, right? And then you have your Latchman's test, and then your pivot shift test. So these are the important tests which you have to remember. And then it is PCL. Again, you have your posterior drawers test. So there is posterior drawer test for PCL, right? And then for your menisci, you have the McMurray's test. So McMurray's grinding test you do for menisci. And then for your collateral ligaments, that is the medial collateral and the lateral collateral, you have your valgus and the varus stress test, right? So varus and the valgus. So for MCL you do the valgus stress test, and for LCL you do the varus stress test, right? So this is the in a posterior cruciate ligament you will have the sac sign. That is whenever you ask the patient to flex the knee, then the tibia will come little posterior, so that is called the sac sign. So before performing the anterior drawers for ACL, you have to always check for the sac sign, and then you have to do the anterior drawers test, right? So these are the various tests which usually they will ask for the sports medicine. And now, as they have mentioned that the medial collateral ligament injury is there, usually it is associated with your anterior cruciate ligament. So this is the answer. The anterior cruciate ligament is the answer, right? That completes the question. And then the next one. In the avascular necrosis of the femur head is due to which of the following artery? Okay, so coming to the avascular necrosis of the femur head, before that you have to understand the blood supply the blood supply of the femur. So the blood supply of the femur head. So it starts with the femoral artery. Then this will give rise to your profunda femoris artery. Right, your profunda femoris, and then this profunda femoris will divide it into the medial circumflex and the lateral circumflex. But what you have to remember is the circumflex arteries are present on the this is present on the anterior aspect, this is present on the posterior aspect, and this will give rise to the retinacular vessels or the epiphyseal vessels, and these are present around the femur head, right? They're present around the femur head, like the superior, the inferior, the posterior, and the anterior. And now this will supply the femoral head according to, so there's a lateral epiphyseal arteries, posterior epiphyseal arteries, superior and inferior epiphyseal arteries. Along with this, you have one more ligamentum teres or the foveal artery. Right, so this is the blood supply of the femoral head. In avascular necrosis, there will be a damage to this blood supply, so there will be a hindrance to the blood supply of the femur, and then you will end up with avascular necrosis. So here what you have to remember is the medial circumflex artery. So the medial circumflex femoral artery is the one which is very important for the blood supply of the femur. So the first best answer would be the medial circumflex femoral artery. The next answer would be the profunda femoris artery, because that the branches from the medial circumflex femoral artery, right? So the first best answer here is your medial circumflex femoral artery. So this is also an integration with the anatomy. So you have to understand the blood supply of the femoral head, and then in the avascular necrosis, it is the blood supply which is hampered, and then the head results in necrosis. That is the avascular necrosis, right? So that is the answer for the question. And next, this is the apparatus which is shown, and this is used for which of the following condition, right? So it is used as a knee ankle stabilizer, or it is used as a patella tendon bearing brace, or a Thomas splint, or a knee brace. So for this, you already know what is Thomas splint. Yesterday we have dealt the Thomas splint is something like this. So it is used for the immobilization of the femur shaft. Knee brace, if something we are using the knee brace, it will start from above the knee, right? So if you think this is the knee joint, it should start from here and it ends it here. But here you will, this is not Thomas splint, this is not knee brace, and knee, ankle and knee stabilizer. So again, something, if you want to stabilize the knee, it should go above the knee, but it is just starting from the knee joint, right? So even if you don't know anything about the question, you can simply answer this as the patella tendon brace, patella tendon bearing brace. So this patella tendon brace, it is used for mainly your tibia shaft fractures, right? Tibia shaft fractures, when you want to treat them as after treating them with the surgeries, you want to put a brace where this is called the functional bracing. The patella tendon bracing is called the functional bracing, where you put as a complete compartment, and you will fix the length of it so that the muscles won't move. And now this, because of this tensioning in the muscles, the fractures are held together, and this will result in the union of the fracture. So this is the patella tendon brace, which is called the PTB brace. So this is called the PTB brace, where the knee joint is left, hence you take the shape of this. So if you see, the knee joint will sit on this. So the patella is not completely enclosed, and just over it you will get a covering of the patella, and back on the posterior aspect you will start little below the knee joint. Hence you can do the movements of the knee joint. So knee movements are not restricted, right? Knee movements not restricted. So hence this is applied in that fashion to not restrict the knee movements. A patient can bear weight and walk. So this is the PTB bracing, where the patient can walk, right? So this is the patella tendon bracing. So that We can move to the next question. A 69 years old male brought to the casualty with a history of fall. The patient is in severe pain. There is tenderness of greater trochanter. So all these are clues. History of fall, 69 years. That is the old elderly male, and he is brought with severe pain, tenderness on the GT, and patient is not able to walk. The lateral border touches the couch. So if you have listened to yesterday's class, I think you will just answer it with ease. So we have even drawn this diagram, right? If you remember my beautiful foot diagram, so this was the foot, so this is the couch, and now if you see, the lateral end is completely touching the couch. Completely touching the couch means it is completely externally rotated. So this completion of external rotation is seen in case of your IT fracture, right? So if it is IC fracture, you see this foot, but it is not completely externally rotated. It is somewhat in between this, right? So this is the amount of external rotation you see in case of your IC fracture. So IC is externally rotated, but when you see that couch touching external rotation, so couch touching external rotation is IT fracture, and in case of IT fracture and IC fracture, the complication is related regarding the unions. So regarding the unions, you will see the regarding the unions, you see this complication. So in IT, you see what is called as malunion. So you see malunion, and in IT fracture and IC fracture, you see non-union. So why a non-union and why a malunion? So in case of this in case of this IC fracture, it means that it is an intra-articular fracture. So whenever there is an intra-articular fracture, because of the synovial fluid have some inhibitory effect on the enzymes which are produced. So there are some enzymes which inhibit the union. So that is why it goes to non-union. And because of the absence of cambium layer, so the absence of cambium layer also will result in what is called as non-union. But in case of IT, there is union, but it is malunited. So here the question is the couch. The lateral border of foot touches the couch, and the answer would be the malunion. So if it is non-union, then it would be avascular necrosis, right? So avascular necrosis, non-union for IC fractures. This is for IT, and pulmonary complications you see mainly with femur shaft fractures. So this is regarding your pulmonary embolism. So whenever they put any question on pulmonary embolism, then you have to answer them with femur shaft fractures. So most commonly seen with femur shaft, and you see most commonly in young male patients. So young males with pulmonary complications, usually it is for your femur shaft fractures. Right, so that completes this question. So moving on to the next. Primary osteoarthritis affects all the following except the hip joint, the knee, the distal pharyngeal joint, the metacarpal. Here it is metacarpophalangeal joint. So here the MCP or the DIP or the knee or the hip. So if you remember the joints, in case of joints, the involvement of joints, if it is PIP plus DIP sparing your MCP, it is the osteoarthritis. If it is your MCP plus PIP sparing your DIP, it is your rheumatoid arthritis. And if it is mainly DIP, it is psoriasis. Psoriasis will also involve other joints, but mainly your DIP joints are involved in case of psoriasis. But whenever there is a sparing of MCP in or rheumatoid, you will see mostly MCP is involved. The PIP is involved. The DIP is also sometimes involved, but mostly it is MCP plus PIP, right? That is rheumatoid arthritis. But PIP plus DIP, when you spare MCP, so if you see, this is the MCP metacarpophalangeal joint, this is the PIP, and this is the DIP, proximal interphalangeal joint and distal interphalangeal joint. That is your osteoarthritis. right? So here the question was primary osteoarthritis will affect knee joint, you already very well know, hip joint you well know, only confusion is between DIP and MCP. So MCP is the joint which is spared in case of osteoarthritis, right? Osteoarthritis is PIP plus DIP, there is no involvement of MCP. But whenever they want to ask you about psoriasis, then the DIP is the one which is mainly involved in case of your psoriatic joint, right? And in case of rheumatoid, please remember that the MCP is the most commonly involved. Rheumatic and MCP. Rheuma M. Okay? MCP. Next, in the fracture of upper 1/3 forearm, it is immobilized in which movement? So, some specific conditions for forearm is because of this movement called supination and pronation, right? So, this is the very special area where you do supination and pronation. In case of foot also you do supination and pronation, but that is a combination of other movements, right? So, in supination and pronation, to do these movements, you have your muscles. So, they are your supinator muscles. So, supinator muscle where you, and then you have the pronator muscle. So pronator is teres and pronator is quadratus. There are two type of pronator muscles, and if you remember, supinator is mainly seen in the proximal radius, right? And this in the distal radius. So proximal forearm, that is, instead of radius you can put this as the forearm and this as the distal forearm. So proximal forearm you see supination, and distal you see pronator teres and pronator quadratus. So now, so the immobilization topic. So whenever you want to put a slab or you want to put a cast, so what you do, so you have to immobilize them in the functional position, right? So whenever it is the distal part which is involved, so you do it in pronation, you do it in the pronation because of the pronator teres. You want to counteract. So whenever you're putting it in supination, because of the action of the pronation, it will pull it in pronation. So instead of that, you put it in a pronation so that the segments, so whatever the bone fragments are there, they are not disturbed. Similarly, if there is a fracture in the upper 1/3 of the forearm, in the upper side of the forearm, you do it with the supination, because there is supinator muscle which will pull the fragment into supination. So for that over pulling of the supination, you put them in supination, right? So this is supination for the proximal 1/3, right? And in the distal 1/3 you go for pronator. Upper 1/3 and then lower 1/3. If it is in the middle, you go for mid prone. So middle, it is mid prone, right? So this is how you have to remember for the forearm: upper, middle and the mid prone. Mid prone you just put it in the mid prone position. For below, for the distal you go with pronation, and for proximal 1/3 you go with supination. So that is how you have to immobilize for the better results of the fracture union, right? Next, a 79-year-old lady had fallen. The following X-ray was taken, and which of the following is the management of the X-ray? So here the X-ray is not very clearly seen, but this has been repeated, and this is the IC fracture where the femoral head. So if you see the femur head, it is somewhat in the varus. So there you can confirm this as the femoral head, that is the IC fracture. So intracapsular fracture. So the treatment of the intracapsular fracture, let us discuss little bit of the treatment of the intracapsular fracture. Intracapsular fracture. So IC fracture, first, if it is this, in the case of, you have to decide whether it is less than 60 years or more than 60 years, the management will differ. If it is less than 60 years, you can still go for your osteosynthesis. What is osteosynthesis? That means you can try for fixing the fragment, that is the femoral head, with help of your CC screws, that is corticocancellous screws, that you do it in a triangle fashion. 3 screws, you use 3 screws and put them in inverted triangle fashion. So this is your inverted triangle fashion. So you put the screws, one screw here, one screw here, another screw here, so that you fix the fragment, right? So that is the cancellous cannulated screws which you use for fixation of this fragment, and you try for your osteosynthesis. If it is more than 60 years, then you have to take a call between your hemi-arthroplasty and your THR. So you have to decide whether between your hemi or the THR. So for whom you do hemi, for whom you go for THR. So usually we do hemi-arthroplasty. So hemi is nothing but half of the replacement of the joint. So arthroplasty is total hip replacement, right? So whenever you're replacing the total hip, that means you're replacing the acetabulum, and this you do for active individuals. So very active individuals, and then involvement of the acetabulum. So whenever there is a fracture associated with the acetabulum, arthritis, right? So if that acetabulum is not very well or not very healthy, then you have to replace it. Then you go for acetabulum, you go for total hip replacement. Hemiarthroplasty for usually very older patients, not very active individuals, right? So you go for hemi-arthroplasty. Hemi is half is this half, the femoral head only. Now if you remember, the hip joint is with femoral head and acetabulum, right? So that completes the joint. Now we are replacing only the half of the joint, that is hemi-arthroplasty, where the femoral head is replaced. So for this replacement of the femoral head, what you use is prosthesis. So you replace this femoral head. So whenever you replace anatomical part of the body with something, this is called the prosthesis, right? So what is prosthesis? The replacement of the anatomical part. What is an implant? Where you fix or you augment the fracture site with additional stabilization. That as you have used plates or the nails, you call them as implants. Then what are the instruments? The instruments are the things which are used to facilitate this implant fixation, right? So the instruments, implants, and the prosthesis. What is orthosis? Orthosis which gives support, external support. Implants is internal support, right? So now we are dealing with prosthesis. You have two types, that is the unipolar prosthesis, and then you have your bipolar prosthesis, right? So unipolar and the bipolar prosthesis. So whenever you use this bipolar, that means the movement between the head and the acetabulum, and there is a small component between head and the larger head. So there are dual movements which occur in this prosthesis. So that is the bipolar prosthesis. And here you have Moore's and the Thompson's prosthesis. So Moore's, you will have two holes. If you see the Moore's, you can remember that there are two holes for fenestrations, the fenestration or the holes which are present for the bone. And then Thompson, how do you identify Thompson? You present with this a collar. There is a collar. So whenever there is an absent calcofemoral, you go for this Thompson's prosthesis. And bipolar is the now this is what we usually use. We use the bipolar prosthesis for hemi-arthroplasty. So if the patient is ready, very active, and if he wants his replacement to be done, so that is your total hip, where you replace the acetabulum and you replace the femoral head. Now going back to this question. So this is hemi-arthroplasty or 79-year-old. So this is a 79-year-old lady fallen, and the fallen X-ray was taken. This is the X-ray. So because as for me, the acetabulum is appearing healthy and it is a 80-year-old lady, usually we prefer hemi-arthroplasty. If this patient was somewhere around 65 to 70 years old, then we have gone for your total hip replacement, right? So here the answer would be hemi-arthroplasty, right? So that is how you deal with the questions. Next is the 10-year-old child. A 10-year-old child comes with the limb and limb shortening. So we have already discussed that the DDH is one where the patient will come with the limb and the limb shortening, right? And that is confirmed by the X-ray again. So if you see this X-ray, so this could not be skiffy because the patient is 10-year-old. And then it is usually in the teenagers, right? 10 years, but between 10 to 14. But here, skiffy is not usually seen in this age group of the X-ray, and fracture neck of the femur is also not usually seen in this group, and it should be Perthes or it should be DDH, right? So here in Perthes you will completely see the absence or the avascular necrosis. So there is completely absence of the head, and here this is a DDH where you see the proximal migration. So here you see there is a proximal migration of the femoral head, and if you remember there is a H line, right? So there is a H line, there is a P line, H line, and there is a P line. So what is H line? Hillengren's line, and then you have Perkins line, right? So H line you draw along the triradiate cartilage, that is the H line, and then along the lateral border of the acetabulum you will draw the P line. This is the lateral border of the acetabulum you have to draw, that is the P line. So this divides the acetabulum into 4 quadrants, and now these 2 are the inner quadrants, these 2 are the outer quadrants, and again these 2 are the inferior and the superior quadrants, right? So now if you see this particular X-ray, the acetabular head, the head is lying in the upper and the outer quadrant. So upper and the outer quadrant, if you see the head, that is the indication of the DDH in case of developmental dysplasia of the hip, where the patient is usually seen in the walking age. That is, the walking age is usually 10 years, right? The walking age you see this type of the head. So that is the DDH, right? So the answer would be the DDH. So Perthes, usually you see there is complete ossification, lysis of the head. So the head is usually not seen. The avascular necrosis of the head is Perthes, and fracture neck of femur is usually not seen in 10 years. And then Skiffy is nothing but slipping of the, it is just slipping of the epiphysis. So because of there is small amount of trauma which is present, and this slip is posterior and medial. So posterior medial slip of this head is called Skiffy, right? So that is Skiffy, and this is mainly DDH. You have to remember that is there is H and P, Hillengren's along the triradiate cartilage, and then you have your P line, that is the Perkins line along the lateral border of the acetabulum. And now this becomes 4 quadrants, that is that is the inner quadrant, outer quadrant. Then you have your superior quadrant, that is your superior, this is the superior and the inferior quadrant. So upper and outer quadrant, if you see the femoral head, that is the indication for DDH, that is developmental dysplasia of hip, right? So that is how you read the X-rays. And if you see the head is smaller in size compared to the opposite side, the head is smaller in size, then there is a proximal migration. And if you see the acetabulum here, the acetabulum is not shallow. Here this is the deep acetabulum, the acetabulum is somewhat straight. So there is a shallow acetabulum. So this is also a confirmation for your DDH, right? So the acetabulum is shallow, the head is small. So the head here is smaller in size, and this is the acetabulum is not well developed, and this is all the confirmation of your DDH, right? And DDH you already know, because the less than 6 months you will treat with your Pavlik hernias or von Rosen splint, right? And then if it is more than 3 years, you do the open reduction with the hip spica, and if it is more than 10 years in case of DDH, you have to go for osteotomy of femur, and then osteotomy of the acetabulum, right? So that is about the DDH. And the next question is, involvement of DIP, PIP and sparing of MCP and the wrist is seen in which of the following conditions? So as we have already discussed, that is the involvement on DIP and PIP, and there is sparing of MCP and the wrist joints is usually seen in case of your osteoarthritis. So osteoarthritis, you have to be careful that there is a sparing of MCP. So MCP and wrist are usually spared, whereas in rheumatoid usually that is the disease of MCP. And in psoriasis there are involvement of all joint, but specifically you will see there is a DIP involvement, and hyperparathyroidism is phalanges. There will be phalanges and the metacarpals which are involved. The metacarpals and the phalanges, there will be increased resorption. So you will see the decrease in the size of this phalanges or metacarpals, or there is increased resorption of the bones in case of hyperparathyroidism, right? And in case of osteoarthritis, they mainly involve the DIP and the PIP joints. So this is the slide which you have to imprint in your mind. So whenever there is a question on the joints, please look for MCP for rheumatoid. If you want to answer it as psoriasis, please put in mind that there should be an involvement of DIP, and for osteoarthritis there is DIP and PIP, and then you have your Herberdens nodes and which is seen in case of osteoarthritis, right? Herberdens nodes and the Bouchard's nodes. Bouchards and Herberdens, which are seen in case of your PIP and DIP. So these nodes are also seen in case of your osteoarthritis near PIP and DIP joints, right? So now let us see the next question, that is the 38-year-old lady had a trauma to the neck, and x-ray is given below. What is this diagnosis? And if you see in this particular x-ray that there is the involvement of the C2. So this is C1, this is C2, and this is a C3, C4, C5, C6 and C7, right? So this is C7. 6, 5, 4, 3, 2 and 1. So this is the cervical spine, complete cervical spine, and if you see there is a fracture here. So if you can identify that there is a fracture here, so this is the fracture, and so if there is an involvement of C1, so there is involvement of C1, this is the Jefferson's fracture. So you have F, first Jefferson's fracture, and C2 is for hangman's fracture. So in C2 you will have hangman's fracture, and usually it is nothing but your bilateral pars interarticularis of the C2 vertebrae, right? So that is your hangman's fracture. And the one more fracture in cervical spine is the lower vertebrae involvement, that is your Clay-Shawler's fracture, where your lower vertebrae, the transverse, the spinous process are the in case of lower vertebrae, that is Clay-Shawler's, you will see the involvement of the transverse process, that is your Clay-Shawler's vertebrae, right? And what is Shivora? Shivora is nothing but spinal cord involvement without radiological assessment, right? So whenever there is no radiological features which are seen, but still there is a spinal cord involvement, that is called Shivora. So let me write it clear. That is, what is Shivora? So Shivora is spinal cord injury without radiological abnormality. So that is your Shivora, right? And this is most commonly seen in case of children. That is what you have to remember. So in case of children, whenever the spinal cord is involved, sometimes the radiological abnormality cannot be seen, and that is termed as Shivora. And the Clay-Shawler's you will see mainly in the C7 vertebrae, that is the transverse process of the vertebrae is involved, that is the Clay-Shawler's vertebrae. And C2 is the hangman's fracture. C2 is the hangman's fracture, and C1 is Jefferson's fracture. So here it is C2, so this is your hangman's fracture. So hangman's fracture is your C2. So in this particular X-ray, what we see is your hangman's fracture. And chance fracture is the seat belt injury. So chance fracture is you can see it anywhere, not even in the C1 or C2. You usually see it in the vertebral column where the seat belt is present, and this is flexion extension type of injury to the vertebral column. That is your chance fracture, right? So that is the answer for this. And so that with that we have completed various MCQs, and these are the upcoming FMG Accelerate sessions you have on 5th, 8th, 9th and 10th. That is how we have planned it. And then you have to, if you are not following the PW MedED, please do follow on Instagram, the Facebook and the YouTube. Please subscribe to these channels, and a very big thank you for you all for participating in this session and making a very interesting session for me. me. Hope you have all enjoyed this session, and at least you have learned a little bit of orthopedics. And important thing is, uh, I have to wish you wholeheartedly that do well in the exams, all the very best, and keep revising till the last minute, and please don't lose hope till you give the best attempt. Right? Thank you.